Well, good morning, everyone. Wanted to thank you again for joining our session. I'll introduce our speakers in just a second, but the session this morning is about a topic that's very near and dear to my heart, interoperability, data liquidity, and transformation. As many of you know, I was a longtime employee of CableLabs, and I worked in the cable industry. I'm a new transplant to healthcare. And I joined the Center for Medical Interoperability with really a singular objective in mind, and that is to help make things better, to reduce cost and save lives. And that's a very personal thing for me. I think we've all had experiences with the healthcare system and people in our family and ourselves. And I just think it's a very important topic, worthwhile of effort. So I'm excited to be here this morning. I want to jump right into the panel, and first I'll introduce our speakers. To my far left is Manish Shah. Manish is the Senior Vice President and CIO of Community Health Systems. And Manish lives interoperability, or the lack of interoperability, every single day, and it's probably 24 hours a day, I can just imagine. So he brings a very strong view for what it's like in the trenches, and he has some good views on how we can change things. And then to my left, a longtime friend and colleague, Mark Francisco. Mark is a fellow at Comcast Innovation Labs, and I like to think of him as an innovator extraordinaire. He's had his fingerprint or thumbprint or the whole handprint on so many of the services that you experience at home with the cable industry, and he's worked in a few other industries as well, and we're excited to have him on the panel. So he has the perspective of possibly a new entrant into the healthcare industry and an innovator and a change agent. So we have them both on the panel, and I'm looking forward to hearing their perspective on things. So I want to start off by just talking about the three big words up there, interoperability, data liquidity, and transformation. And then I thought I'd just ask Manish if he could just share his views on when you say those words, what do you mean?
So first of all, good morning. It's an honor to be here this morning. This is an interesting sort of chasm of an industry that's sort of cracked the nut on how you organize and simplify the way in which technology gets consumed, with probably the most chaotic. So you talk about two different extremes. They're probably represented here today. Healthcare, as you know, has gone through tremendous transformation in the last few years, largely because of the Affordable Care Act. The Affordable Care Act, though, unfortunately, only focused on digitizing the medical record, and in the process, essentially, I think, made the problem worse than where we were before, which is you now have digitization where the thing that touches the patients is essentially left completely unattended to. Now, the whole trick of digitization footprint is to actually provide better patient care by a total ecosystem that works together in a seamless way. So interoperability becomes an absolute essential to how you harness the information, and therefore the data liquidity. It's essentially creating that fluidity that allows critical decision making with appropriate data at the right point of the care setting in an expeditious, reliable, and safe way. So it is a significant challenge, and I don't know if we have the slides, but there's a slide that I think we actually have, and if a picture tells 1,000 words, there you go. So that's what the world of delivering patient care looks like today. And so while we've taken the other extreme, which is a lot of paper that used to be created in documenting patient charts, and transformed that to a digitization footprint largely, this is what the end user experience looks like today.
Thanks, Manish. And Mark, from your perspective, do you have any different viewpoints or anything to add to that? What do you see when you see this picture?
First of all, I have a great deal of respect. I'm flanked by two medical professionals here and have followed a panel that was the CISO panel. While I haven't walked in their shoes, I am sitting in their chairs right now. So, those of you who have been in my office in Philadelphia know it looks just like this, except it's all big screens playing HD and 4K TV and all that sort of thing. We're coming in from a different point of view in the cable industry and looking at it from an innovation perspective. First of all, we start our interoperability point where we began as the person, as the user, whether that be somebody who's a medical professional, a caregiver, a patient, or somebody that's associated with taking care of those who are in that industry. So we start there and then move our way through the electronic and mechanical systems that get the data and the prognosis and the adherence needs all the way back to the healthcare professionals. So we're sitting there in the middle. We're looking at the means to ensure all of the policies and the practices that the healthcare industry is interested in, yet add a little bit of an extension to their abilities to get towards the home and towards mobility as well.
Okay, great. So let's talk a little bit on the technical side, what you're both dealing with, and another diagram, maybe
So the world of
technical diagram of that last picture.
So the world of care delivery is one of very complex sort of permutations. So we talked, the last session talked about how do you contain and secure medical devices that are touching patients. Well, imagine a world where every single vendor that sells those devices has their own proprietary management structure in the way those devices are capable of plugging in to share information. And then imagine a world where every time you want to connect one of those devices, there's a toll associated with it. So every single device, the manufacturer charges you to create a proprietary interface to a point-to-point data sharing. And imagine a world where you've got hundreds of thousands of these devices. And by the way, when you pay for one, you've paid for one. So it's a challenge of how you get safety, reliability, and economics, which are incredibly complex in this industry. And that's what the world looks like today, is you've got devices that are all over the place, some that can integrate, but you've got to pay a toll for, some that actually are so proprietary that the vendor insists on managing. So you talk about security, nearly every device and every manufacturer of any healthcare IT insists on actually having a backdoor for the sake of quote unquote support. And that's the world we're dealing with today. And it's a complex set of complexity that actually makes the digitization of documentation look like small potatoes in the grand scheme of things. And so having a organization structure that can act as the broker of mediation between those who consume and those who actually provide, there needs to be a balance and a structure around it, which, obviously CableLabs figured out a long time ago is, if you think about the seamlessness of the experience there, and Ed and I were talking about this morning, is the actual endpoint device that all of us actually consume today in household has changed dramatically, right? There was a time where cable actually delivered a set of cable channels. Today, those same wires actually carry on-demand content, very high content of, the amount of content that is actually delivered from it. And, oh, by the way, it carries data without really change. So the end devices have changed, but as consumers, we actually do not see a significant difference in the way televisions are plugged in to homes today. You talk about simplicity, and that simplicity, when you actually imagine it being applied in the healthcare setting, changes the dynamics, the economics, and the cycle time of actually applying these devices to deliver patient care in a dramatic way.
That's excellent. Mark, Mark, so Manish talked a lot about what it looks like inside of a health system, the current state of interoperability and all the proprietary interfaces. And I'm wondering, for you as a potential, or Comcast, or any company as a potential new entrant into healthcare, and wanting to innovate something new, what are the effects of that downstream? What do you see?
Yeah, for sure. There's, I look at them as guardrails, and I've learned a lot of vernacular over the past 2 days. Things like fail-safe and cyber hygiene. I have a whole list here I can rattle off in my trip report when I get back. But the idea of having the constraints of the existing systems and trying to interoperate with them, it's not something that's unfamiliar for an IT industry to deal with. There are rules like HIPAA and all those other things that provide additional guardrails, and I look at those like a set of security requirements. I think we can approach it from a traditional product delivery, one that is high value, high expected service quality, but go about it in a similar fashion we've done in the past, which is look at the interfaces. Look for the places that we can start to apply standards to the interfaces, and working from the person back out to the clinical environment, there's a number of locations that's already occurring. We've got everything from PHY standards, an example might be Zigbee, all the way up to semantic standards, an example might be LOINC, and then on into security standards. And then the last piece of it is, and this is something I believe we've gotten a pretty good expertise, is starting to look at how to apply DevOps models of operations, which is constantly looking at not backing into things like security, backing into things like patches, but actually operations and development are tied in a constantly flowing cycle. Mm-hmm. So that even things like security or interoperability are constantly evolving in the process, which means you patch before a vulnerability is ever exposed, or you increase the level of service as new devices come on. And then the last thing is, I would say it would be a far stretch for the cable industry developing medical devices, but it's not a far stretch for the cable industry to be interoperating with them, which is provide the conduit of choice to get data from the patient or the caregiver to those who need to evaluate and act upon the data.
Okay. I'm going to bring up this chart. This shows a more organized architecture, or a view of a more organized architecture of the health system. And we could talk about this a little bit, but I want to bring up a story that a well-respected physician shared with me, and he's a member of the Center for Medical Interoperability Technical Advisory Committee. And he sat down with me about a month ago, and he explained the practice of medicine as storytelling. And he said, basically, when you go to see a doctor, you sit down in front of the doctor and you tell him or her a story. And the doctor listens to your story, and then they think about it, and maybe they run some tests, and then they turn around and they tell you a story. They tell you the story about how they're going to treat you, or what you need to do, the changes you need to make in your life. And with the digitization of healthcare, there's been a cost that has gone with that process, which is we've lost a lot of the story. So we've taken what used to be an actual story written down on paper, and we've broken it down in little bits of data and just kind of sent it everywhere. And he said, what we really need to do is we need to get to a level of interoperability and contextual awareness where we actually get the story back, because that's really important to the practice of medicine. Here. So I just wonder if you can reflect on that and share any intuition you might have on that point. This is a surprise question.
Oh, it's okay. So the hypothesis, and this is something my team is very interested in testing out, is this idea that building up a behavioral model is a great indicator of health and a great way to help those who provide professional health care to provide interventions. And the challenge here is we're going to cohabitate what I familiarly call the activities of daily living with the secure and trusted medical data. So we've got these two pools that we want to set next to each other. One has high accuracy, high trust, higher integrity. Another one has a lot of indications. So things like, one of the hypotheses we use is that television viewing behavior is an indicator of health, for example. So first of all, the fact that you're interacting with television, let's face it, television is a companion to aging and infirmity. It's also an indicator of your emotional state, and it's a sense of activity. As minimal as that activity is, it may be that all you are capable of doing for the moment. Could some of that data be as useful as some of the vital sign data as we start to mix these pools together, but do it in such a way that we're not parading this as medically durable data, it's paraded as lifestyle data. We hear about, even in, precision medicine, that lifestyle is one of the most important contributors to precision medicine. Lifestyle to me is, well, what did you eat this morning? How active are you? What are your behaviors and activities? Are you social in nature? Are you reclusive in nature? And those sort of things. So it feels like even the medical community is pointing in this direction. As a home security provider, we're used to dealing with transactions that are things like doors opening and motion and activity. Is there a chance now and an opportunity to keep people well, to help caregivers get a better feeling of peace of mind, keep them less stressed, and then provide the medical professionals data that they can use to help to the continuity of care?
So that's the story of your whole life.
Yeah, and I think that's spot on. I think if you think about the ability to pivot the way in which care is delivered, you have to think about the actual data, the real-time data that gets generated at the endpoints that touches the patients. And those are the real indicators, because ultimately, if you think about the workflow, today's workflow is one where clinicians and caregiver teams are reading all of that data and then essentially keying it in to some big monolithical system that was put in that then figures out, and hopefully can figure out the computationals of what is this data telling us, assuming that it was accurately entered. And then it actually, at some point, does the permutation and actually gives you feedback. Well, that entire chain, every second, every minute that goes by matters. Where I think the compelling argument is if you can create data liquidity from the endpoint upstream in a seamless way. Imagine a world where you actually take a bedside monitor out of a box, no matter who the label provider is. Plug it in, it actually self-discovers, it authenticates that this is a certified device, it plugs into some magical platform layer that actually integrates these devices and starts talking to the EHRs so that the EHRs can provide the diagnoses, the actual data that's streaming can actually harmonize. So when you talk about analytics, the entire promise of delivering better patient care through an analytical-driven engines can only come to fruition when the real-time data is being fed from these medical devices that are actually plugged, touching the human beings that we're caring for. And the ability, so if you look at this diagram, what it's really saying is literally all of our time has been spent on the top layer, which is green, and therefore there's a lot of conversation that get had around analytics and innovation. Well, analytics and innovation can only be had when you actually traverse down to what I call it's the too hard bucket. And generally human nature is leave the it's too hard to the side to figure out. And I'll tell you, I think it is absolutely amazing that there are thought leaders in healthcare, like the Gary Mary West Foundations, who saw the opportunity to go, hey, there is a tremendous opportunity here. While most people are focusing on digitizing their paper, the real holy grail is the liquidity of data at the endpoint, and created this foundation, the Center for Medical Interoperability organization, that truly focuses on bringing the vendor community, the provider community, the clinical community, and the entire business model together to say, hey, you guys got to work together to create a certifiable way in which these devices can be trusted and create interoperability amongst them so that we can truly take advantage of the health signals real time to pivot the way in which care gets delivered.
You know what's interesting about, well, there's a lot of interesting things in what you said, but something that strikes me is, we're talking about taking data and transforming it into information and wisdom, actually, point of care. And as a throwback to the last panel, it goes all the way down to, can you trust that medical device? Can you identify it? Can you authenticate it? Can you authorize it? Can you secure it? Because my hypothesis is that you can't really interoperate with a device that you don't trust. How do you trust the data if you don't trust the device? So we really are starting with connectivity and security as the foundation to create plug-and-play interoperability and all these things that flow from that.
And oh, by the way, sorry to interrupt, but oh, by the way, that cycle time of today taking a device out of a box and all of the different people that have to touch it in some magical way, it's measured not in minutes or hours or days, it's measured in weeks and months. Because you've got to get the security guy to actually vet it and sign off on that interface. You've got the IT people to actually build the interface. They got to talk to the vendor who actually manufactured the device. The manufactured device has to touch it on their end to actually configure it. I mean, it's a pretty complex process. I know it sounds pretty easy, right? You take out a device and you plug it in. But today's world is actually not as simple as that. And so literally, therefore, the end result of that is there is true lack of substitution in the end device market. You have a device and you stick to it because it's the path of least resistance. And it doesn't matter whether it's the most innovative device that's available out there, but you actually measure it by, do you already have the interfaces written, and do you already have it integrated, and just buy another one if you need another one, rather than really truly looking at, what is the true innovation that's available for the right economics, and buy it because you can take it out of the box and plug and play and not have to wait weeks and months to actually establish the level of integration for it.
Yeah, my hopes are, when I hear that, I hear about workflow, and another term is device lifecycle management, right? It's from the time it's put in the box, and maybe it's even pre-authorized, all the way to the point it's reached its end of life.
Absolutely.
I think we need to focus more on the end of life of devices. We always hear about these devices that become zombies out in the network. That's just a technical requirement to allow devices to stop operating after a period of time. If they no longer are relevant, if they're past their useful lifetime, they could literally force themselves to stop communicating, so we don't end up with issues and vulnerabilities. So I think that's a charge I put out to the technical community, is look at the unboxing, but also look at the the recycling situation.
That's a good point.
So I think we just need to equate the vernacular. Healthcare certainly has a lexicon. IT, cable, media has a lexicon. We just need to look at the equivalents on some of the terms.
So I guess the two most vulnerable times then are not only onboarding, but onboarding and offboarding.
Offboarding, yes, for sure. And it's a healthy thing to think about, particularly because there's such a rate of change. The closer you get to the consumer market, the faster the change is likely to occur. Because of price and style, and the rate of technical change just keeps accelerating.
Yeah, I really suspect that we are not only going to go through a technical transformation, but actually a cultural transformation in the healthcare industry as we really adopt different approaches and really embrace interoperability.
And in the comms industry, as we embrace healthcare in those endeavors as well.
True.
It's a double-sided.
And your largest challenge actually is one of informing and communicating, because candidly, a lot of people in healthcare don't actually understand interoperability. They don't understand that. What does that really mean, right? So
a lot of people can't even say it.
So you really have to. It's the first conversation with senior leadership about. It's almost like having the same conversation that most, I think, senior leaders got it, sort of tuned into, because they actually started reading about all this cybersecurity and stuff. Interoperability is not sexy. Nobody writes about it, and they don't really necessarily read about it. When they do read about it, they go, well, this is complex. This is an IT thing. The IT people worry about it. But I think that when they see the economics and the actual complexity that goes into delivering care, that, I think, should have them sort of tuning into this conversation as well. And then, God forbid, you actually drift that conversation into data liquidity, and they go, what? Data what? They go, liquidity? How do you actually turn data into liquidity? So that, when you put those two terms together, they sound pretty, and they may be difficult to pronounce, but when you actually have the conversation with leadership about tuning into why interoperability matters, because in the end, these senior healthcare leaders are going to need to play a pivotal role in actually having difficult conversations with the vendor community, who is set in their way and see no incentive to really change, right? Because they see that as a competitive threat, because this is the way they've worked, this is the way they've actually dealt with these devices, this is the way they've sold them, and they haven't sold them to the IT people, by the way. They sell them to the end user. Generally, the administration team of a facility makes that decision to essentially, maybe they do it on features, maybe they do it on relationships, but when you think about the entire business model, the way it operates today, and why or how it will have to pivot, it's more than just about defining a standard. It's about actually moving an entire herd to a different way in which they actually think about this problem.
That's actually a good segue. I'm going to go right to this slide here, which talks about the herd. So we know, and I've experienced this firsthand at CableLabs through successes and failures, that a good technology specification doesn't necessarily lead to a good
Absolutely
innovation.
right.
Doesn't mean it's going to get adopted. And unless we create something that's adopted at scale, we've really just had a lot of fun, but we didn't accomplish anything. So how do we get there from here? We've talked about why interoperability, what it should look like. How do we do it?
I'll take a crack at it, and then you can crack in. So I actually think if you look at this diagram, it looks pretty simple, but and when you start to actually think about it, you'll see that there is tremendous sort of similarities from other industries, right? So let's talk about regulatory. The FCC actually governs a lot of the devices that actually are used in medical care delivery setting. Today's world, the reason those devices don't get iterated, the reason they stay stagnant, is the idea of actually getting those recertified is an incredible challenge, right? So you got to get that entire sort of organizational construct into a buy-in of, this is important to do, and it makes sense. So the entire regulatory body will have to have an understanding and adoption of this sort of, future state that we want to try to drive the industry to. If you think about the clinical team, they have a loyalty and affinity to devices that they're familiar with and are very accustomed to using. And if you go on the other side of that, the ecosystem, which is made up of the vendor community and the HIT vendors, there is a whole set of push-pull that occurs between the clinical and the ecosystem, who influences the way in which clinical people embrace the technologies and then kind of just stick with it, right? It's a path of least resistance. Then you've got the technical side. So you've got the whole, security and integration. There are a whole set of challenges that, kind of come to fruition in terms of how you think about solving this problem that somebody has to mediate. And then there's a business architecture, which is how do you actually, when you get all of that other stuff done, how do you actually define standards that simplify the transaction sets that essentially can act in a liquidity sort of way to be able to fluidly talk to foreign systems in exchanging data? That entire business architecture is all about data flow in the most relevant, simplistic way that has to come together. So this ecosystem truly is no different than a lot of other industries that have gone before. That what I see is a great opportunity to take on this challenge in healthcare by just tuning into what others have gone through before, whether it's the banking system. If you think about the way in which it evolved, the cash stations of the world today, they're very secure. Nobody hacks into those. You don't hear about those. They don't get ransomware. But I think if you think about that sort of vertical, you think about the cable industry vertical, there are great learnings that actually have the promise of acceleration in the way healthcare solves this problem.
What I like about this chart is it's an important but subtle thing, is that it's patient, member, or user-centric, right? They're in the center of the chart. It's got to start there. If you're not providing a benefit, you don't get adoption. So you have to consider things like usability, and then ultimately, what's the value quotient of whatever we do? The second piece of it is to have an incented party that comes along with you on it. It's not a matter of forcing a piece of technology or an application into somebody's hands, but filling a demonstrated need. And maybe even considering the sphere of devices that the user already is familiar with, as opposed to trying to thrust a new piece of technology into their hands. Consider adding extraordinary features to an ordinary device might be a better approach to it. So as opposed to saying this new, what do you call it, thing that we're going to put in your house, here's the things you're already familiar with. How can we start to use that to give you the things that you care about? And the challenge, a lot of this is around senior populations, because of just statistics and everything else would say, is seniors are not one monolithic element, right? So if you take genetic diversity, and in engineering terms I say cross that with lifestyle diversity, then you get what becomes a senior. And the spread and the permutations are infinite once you get to there. And you start getting into the value equations. What do a variety of seniors value? It tends to be quite a bit different than millennials, or different than folks in their formative career years. It's a lot more about legacy. It's a lot more about the flexibility to do the things that they really planned on doing as they get older, which is travel, be with family. How do you play to those values as opposed to things about aspirations, things about stature and all that? So all of that goes into this very complex recipe represented here in about 8 different pie slices.
It is complex in some ways. I like to think about it in terms of the adoption chain and co-innovation. So for an innovation to be a good idea, who are all the parties that actually need to adopt it for it to work in the market? And then what other innovations need to happen alongside to really amplify the value?
Yeah.
And I think that gets represented in the picture. Thanks for pulling out the individual aspect of it. That's pretty good. And Mark, I wanted to go back to you and ask this question.
Oh, the word clouds.
The word clouds.
We need a word cloud.
Yeah.
And I was talking about lexicon comparisons, and when you look at the slide, you say, okay, are we talking two different things, or are we really talking about the same thing and opportunities? Now, I would say in the non-healthcare sector, we have a little bit more flexibility to use open standards. And open sounds really scary, as if like open means vulnerable. But open means open to development and evolution. So open source is something we embrace. And the reasons for it is the development and the repair cycles are much, much quicker. It doesn't mean that somebody can hack your software. It means that many people, you're crowdsourcing the fixes. There still is a responsibility for those who check in the repairs. So I'd rather have a world of people helping to keep my software safe than one person who's looking for plausible deniability to allow the vulnerability to slip through. And then you look at the variety of different other technologies that we don't think twice about in communications and applications and social networking and all of that. And how do you map those into the vernacular of healthcare? I see a lot of equivalence in here. And it's just a matter of making sure you stay within the guardrails. Always make sure integrity, safety is key, and those things. But our approach is to really look at the application of things that we're comfortable with, feel have high integrity, high levels of customer experience, consumer adoption, and apply that to triple aim or whatever you want to say is the specific objectives of that healthcare entity.
Very good. We're getting short on time. I'm going to go to our last slide and ask for maybe just a 30-second, my last question, just a 30-second answer from response from both of you, and then we'll bring up some audience questions. So we go through this whole journey, and we get interoperability and data liquidity. My question is, how can that transform healthcare? What do you think the big changes would be, or will be, since we're going to succeed?
I'll let you go first.
Okay. Well, first of all, I think it already is. We're seeing more and more things like the fire standard and HL7, albeit they still have generations to go through to be stable and converged and all of that. We're seeing more and more activities take place that advocate and aid sharing. You're seeing standards, including things like Bluetooth and Zigbee, start to be adopted by IoT devices for health, for biomedically grade health monitoring. Microsoft, we heard a bunch of different use cases where they're prescribing different monitoring tools into the home that can help. So I believe it's already there. What we need to do is now scale it. Scale it through adoption, scale it through greater emphasis on the interoperability aspects, to nail down the aspects of software lifecycle and certifications and getting things that ensure the integrity of the devices before they show up in the field.
Okay.
So I have a little bit of a different perspective on that. I don't think we're quite there. And I think it would be kind of interesting, it just occurred to me, and Ed, you could actually take this on, but if you actually took the trajectory of adoption and innovation from where, let's just say, cable started, before they realized that, hey, we need to establish standards, and sort of where we are today and how long that took in terms of a timeline to actually adaptability, and you actually map healthcare to it, I would argue that it is probably on a much more rapid trajectory than maybe other industries that have gone before it. Largely because I think we're not trying to solve while it's unique in healthcare, there's a tremendous opportunity to learn from others to actually reduce the cycle time. One. Two is, I don't think it's sort of, it's almost like the security conversation. It's not if, it's when. The cost of not having interoperability and data liquidity, I would submit, stagnates the way in which care is delivered. So we got billions of dollars invested in digitization path that comes to an abrupt stop without somebody cracking the code on getting interoperability from end to end, figured out, make that seamless, make that easy to consume so that you can really focus. And I would argue you'll even get to data analytics stagnation if you do not figure out a way to deliver more real-time data that is at the bedside to these complex systems that we put in place, spending billions of dollars and countless man hours putting in. So therefore, I would argue that it's not an if, it's when, and I would argue that it is on a significant acceleration. So we will see that, and the promise of that, in a much more accelerated fashion than perhaps other industries have. That would be my hypothesis.
Very good. So we've timed the presentation almost perfectly, except that I didn't leave time for questions, and I was wondering, does the audience give us permission to see if we have questions that came up? Okay, so wondering, informed, why is healthcare so much more expensive in the U.S. than in other developed economies, and how do we fix it?
Anyone?
So this is a pretty complex question, one that gets compared to a lot. I think it's complex for many reasons. It is turned into, healthcare in the United States is turned into an entire ecosystem backbone that is driven largely by the contribution that it makes. Nearly 20%, I think it's more like 18%, but I'm just rounding up, but 18% of your gross domestic product accounts for healthcare spend. And so when it takes on a life of its own, it's really not about healthcare anymore. When I define healthcare as people helping people get better. This has turned into an entire economic cycle that has actually gotten complex, where the payers actually largely dominate healthcare in the way it gets experienced, in the way it gets delivered, in the way it actually. And so when you think about other countries and how they think about the economics of delivering healthcare, you'll find nearly every single model that gets compared to is a model where the patient has a significant responsibility in their financials and their well-being in the way healthcare is consumed. In the United States, healthcare is consumed with really no regard for how much does it cost, who pays for it, right? And unless the consumers take a much more active role in participating and asking those questions and making better choices in the way they consume healthcare in an informed way, you'll always have those buy-divide comparatives where the U.S. is on one side and the rest of the population in the countries are on the opposite bipolar side.
Very good. We'll take one last question, and I apologize. We'll probably other questions that we won't get to, but we'll be around for lunch, and please feel free to come by and ask questions. So I think, was it Yogi Berra that says that predictions are exceedingly difficult to make, especially when they're about the future? So this one is asking us to make a prediction for the future. And so what is the time frame for the desired end state? And let's put this in a statistical. What would be the time frame to get to 80% of the desired end state?
That's suggesting we've defined an end state as opposed to a continuum. I really would suggest that we're taking steps towards meeting the objectives of improving the overall experience, productivity, all of the things we've heard about that we want to do in healthcare, health of populations and things like that. We can start implementing very soon. There's development underway, there's technologies in hand. It takes time to get this deployed, it takes time to get this accepted and approved and part of standard practice. But you are already seeing just the foundation of some of these transitions in healthcare. So I look forward to, in this day and age in technology, change occurs very quickly.
Mm-hmm. Yeah.
So I think that the two statements are, you'll see it soon, and the second thing is, there isn't an end state.
Exactly. I agree with that. Well, Manish, anything you want to add?
No, I actually think that it's about baby steps that lead to acceleration. I think the first is defining the foundational, and then getting other people to embrace it and gravitate towards it, and helping them understand why gravitating to it makes sense for them, why their business model not only stays intact, but perhaps actually creates better value upstream, where they aren't focusing on sort of that, benign stuff that protects their footprint, but rather focus on perhaps moving upstream with, analytic interjection, real-time from the devices to the EHR systems. So there's a tremendous amount of value statements that actually you can sort of theorize, but you got to first define the ecosystem and then help people gravitate towards it. And that gravitation should provide momentum and acceleration, because this has to be about an ecosystem that moves in tandem towards the promised land.
Very good. Thank you. Well, thank you again for the audience, and I'd like to thank our
Thanks for the opportunity.
Mark,
Appreciate it.
for joining us.